talk by Mike O'Neill, a perfusionist in London, Ontario from Canada, and he will be speaking about microvascular monitoring during CPB.
Hello, everyone. My name is Mike O'Neill. I'm a perfusionist here in London, Ontario, Canada. Just going to present today on some of the research that I've conducted over the years and some of my insights on microvascular monitoring. So to help guide the optimal delivery of blood flow during bypass, perfusionists relies heavily on cardiac monitors that reflect global perfusion status or macrohemodynamics. So this includes parameters such as heart rate and mean arterial pressure, and even values such as lactate and venous oxygen saturations are still representative of central perfusion markers. However, normalization of these parameters do not always ensure that sufficient oxygenation occurs at the microvascular level. So therefore, since the macrohemodynamics is limited in predicting the state of the microcirculation, there's an increased need for microvascular monitors that can help guide therapeutic targets during bypass and improve clinical outcomes. When we talk about goal-directed perfusion, this essentially is a type of blood flow management technique with the primary focus being on global oxygen delivery and some other calculations. Even oxygen delivery or GDP calculated values are considered as macrohemodynamic values. If the microcirculation is injured or unhealthy for whatever reason, it doesn't matter how much oxygen is delivered to the tissues. This has been documented in extensive research with sepsis patients. Therefore, it's the microvascular blood flow and the control mechanisms that are just as important as the oxygenation values themselves. So these are just some of the monitoring devices that we've used in the past. Although these technologies help us to better understand microvascular perfusion, they do come with some limitations. First, OPS imaging provides only a snapshot of the microcirculation. Too much pressure may underestimate blood flow, and there's a lot of movement artifacts involved. STO2 values are viewed primarily as a measure of regional venous oxygen saturation, which is not a true indicator of microvascular blood flow and the regulation of oxygen. As I said, it's that control mechanism that we're after. And again, a need for monitors exists to continuously track real-time changes of red blood cell distribution within the microcirculation. So this leads to our subsequent study. Basically, we asked the question of whether we can track changes in microvascular hemoglobin levels over time and use this as a surrogate for red blood cell distribution. So we aim to investigate this by applying a custom broadband wave NIRS monitor. And we had previously built this and used it successfully in the ICU at LHSC. And we looked to determine the feasibility of using it on bypass. Our hypothesis was that this isosbestic NIRS device would be successful to provide continuous monitoring of MHC values in the skeletal muscle of the thigh in real time. In fact, we actually believe that changes in MHC would correlate to some various interventions during bypass and maybe provide some insights into microvascular function. So with the design and build of our own NIRS device, therefore we have the luxury of accessing the raw data that's needed to reflect the time-dependent variability in MHC. And you can see here this device is clearly contained in a carton. Looks like it belongs in the hospital already. Key to our analysis is processing the light intensity signal from our spectrometer at the isosbestic wavelength, like I said, And this is of hemoglobin, of course, in the near infrared range, which occurs at approximately 798 nanometers. So as at this wavelength, the amount of light absorbed by hemoglobin is independent of whether it's oxygenated or not. Therefore, we don't measure hemoglobin directly, but we measure changes in the optical density at that isosbestic wavelength, which gives us changes in MHC over time. So this is a single patient representation from our study that shows macro hemodynamic data versus the first time showing delta OD measurements of the microcirculation. We had presented this back in 2019, this particular graph, and it looks a lot like goal-directed perfusion that we see on some of the heart-lung machines today, except for the fact that we're focusing at the microvascular level. So obviously in figure A, this is pump flow rate. Figure B represents the patient's mean arterial blood pressure. And finally, the blue curve in figure C shows changes in optical density and how it's affected by flow rate and mean arterial pressure. Also in figure C, the dotted black line represents the patient's own baseline delta OD values, which we had determined pre-bypass. And these values are important as we use them for one of our key measurements, being the area below baseline. Again, a metric that has become similar to goal-directed perfusion. When we zoom in on this near signal, we can see there's distinct changes in that optical density, and this is associated with mechanical ventilation. So in figure A, the OD signal can be seen just prior to pump on, and this is in association with the ventilator, and then it disappears once bypass is initiated and the ventilator is turned off. So you can see this sawtooth pattern here being the ventilator. So this pattern represents changes in MHC as the venous return to the heart fluctuates with each breath of the mechanical ventilator due to changes in the intrathoracic pressure. And then in figure B, obviously, the ventilators turn back on just prior to the end of bypass, and these oscillations, ventilator signals reappear. So as a feasibility study, these changes that we see here in optical density were very encouraging and added some strength to the fact that we were able to detect what we had hoped for. Now, for the sake of time, I'll just fast forward to a multilinear regression model. So in the case of area below baseline, the area multilinear regression revealed that area below baseline was significantly dependent on the pump duration. So in fact, for every 10-minute increase in the pump time, the area below baseline was increased by 0.026 units with a p-value of 0.001. Our second multilinear regression model revealed that post-pump lactate was significantly dependent on the area below baseline. So in fact, for every 1 unit increase in the area below baseline, post-pump lactate was increased by 87.6% with a p-value of 0.025. So in summary, as area below baseline increases with pump time, this would suggest the tissues are less well perfused with hemoglobin. When we look at lactate versus the area below baseline, we see as the area below baseline goes up, as does the lactate. So this leads us to our final study. And in this one, we ask ourselves, is it possible to detect the dynamic behavior that speaks to the regulation of microvascular blood flow? So using laser Doppler flow study concepts, we applied a continuous wavelet transform analysis to that delta OD time series that I just talked about. And we did this to reflect the dynamic variability in red blood cell distribution. And this was done at some key time points during bypass. By looking at the dynamics of hemoglobin content, we can gain insights in terms of the regulatory system. And obviously, this may not be reflected in some of the macro hemodynamic data that we collect. So our hypothesis was that changes in signal power at various frequency bands associated with microvascular origin will happen within and between patients, and that this information may provide some insight on dynamic variability as the microvasculature adapts to oxygen supply and demand situations. So LDF technology has been used to study the periodic oscillations that occur during microvascular perfusion of the skin. So in doing so, they've defined 6 frequency bands, each linked to a proposed physiological event. And these events include intrinsic or local mechanisms of regulation, such as metabolic in band 1, endothelial regulation, band 2, neurogenic, band 3, and myogenic, band 4, as well as some of the extrinsic or central mechanisms, such as respiratory, found in band 5, and cardiac rhythms found in band 6. So this figure represents that of a single patient data set with the delta OD time series shown at the top in blue. The colored image below is a plot of power versus frequency versus time for oscillations that are attributed to components of the microvascular system. So the color tells us what power is associated with the wavelet at every frequency over the time interval. The figure to the right shows that the global power averaged for each frequency band over time. Bands 2 to 4 that you see within the red rectangle represent the microvascular bands, and these are the ones that are of primary focus in our study. So I'll try and move my mouse without my computer crashing here. So basically you can see up here, this is the cardiac bands. Can't see this one too well, but it disappears once bypass is started and it reappears when bypass is discontinued. Same with the ventilator here. Disappears and comes back, ventilator turns back on. And then within the microvasculature, you can see these spikes along the way. And these are in sync with some phenylephrine boluses that we had given during bypass. And then some of the lower frequency bands here, especially at pump on, you can see it's very active here. And then again, it's very active at cross clamp off. So pump on, probably reflecting the hemodilutional effect, and maybe cross clamp off reflecting some type of ischemic reperfusion scenario. So the following figures show the effects of 4 boluses of phenylephrine spread over a 15-minute time interval during bypass. So figure A, there's similar global power. So each one's basically triangular shaped for each bolus. On figure B, most of the global power is concentrated at the base in bands 2 and 3 here. And that happens with each bolus of phenylephrine. However, here the phenylephrine causes vasoconstriction and abrupt changes in MHC. So this may not reflect a regulatory change in each frequency band, but rather a reflection of a simple time domain event. However, though, as the time between the boluses becomes less and the amount of global power seems to be decreasing as time goes on, and this happened despite an increase in dosage requirements. So basically, in other words, as phenylephrine became less effective or refractory, the global power had decreased. So again, for the sake of time, here are the percent power calculations for each frequency band through 2 to 4. So in figure A, the percent power in band 2 significantly increases at both pump on and cross clamp off time points when compared to pre-bypass values. Then they return to baseline values following bypass. Conversely, in figure B, a significant decrease in band 3 occurs at bypass on and cross clamp off, again relative to pre-bypass values with a subsequent return to baseline. And finally, in figure C, there was a significant decrease in higher frequency band 4 at a pump on only, with a slightly higher percent power seen post-bypass compared to pre-bypass values. So the shift in power to low frequency bands at pump on may be a reflection of hemodilution, as opposed to the impaired ability of the microvasculature to redistribute red blood cells. However, we do speculate that the microcirculation may be under stress as power shifts towards lower frequency oscillations at subsequent time points. So in summary, the current use of NIRS at the bedside is a non-optimal way of assessing oxygen delivery to a patient. A more practical monitor tracking MHC along with continuous wavelet transform analysis could be useful in providing information about oxygen supply and local tissue demand. And the second point there, our current research and related future work is an important first step and compelling prerequisite for such a monitor. There are some key metrics established from this research, which could be helpful in guiding perfusionists to improve best practices, such as maintaining MHC at or above relative to baseline levels. And the amount of time and magnitude spent below a certain threshold level could be a surrogate for low oxygen delivery and may be prognostic for adverse outcomes. And basically that becomes the holy grail, as the next steps would be to see what therapeutic interventions can be done to bring values closer to baseline. And finally, trends in B4 that we see that I didn't present due to time, related to changes in lactate are also very compelling. And that's it. Thank you very much. This could be the future of our goal-directed perfusion.
Okay, thank you so much. This is a recorded presentation, and I want to introduce the other presenter, Frank